we have Dr. Molly Regelmann from Children's Hospital at Montefiore talking to us about ALD standards of care for pediatric endocrinology.
Thank you, everyone. Thank you, Elisa and Miranda. Thank you for having me again. For those of you who've been in the audience before when I've talked about this, there's a lot of repeat because there hasn't been a lot new in endocrine this year, but I think there have been a lot of great discussions and hopefully some collaborations from this. So the objectives for the talk, I'm going to go over adrenal pathology and the manifestations of adrenal insufficiency in adrenal leukodystrophy. And we'll talk about the surveillance guidelines that we currently have and likely need to be updated. And then I'm going to discuss treatment of adrenal insufficiency, which I think usually there are a lot of questions about. And then we'll go through a little bit about testicular dysfunction, which I don't think has been mentioned yet during this meeting. So just really quickly to review normal adrenal function for the non-endocrinologists in the room. Normally, you're going to have your pituitary gland, which sits at the base of your brain, making ACTH, which turns on your adrenal glands to make cortisol. And when you have enough cortisol around, there's some negative feedback that goes back up to the pituitary in the brain and says, turn off that ACTH. Normally, cortisol and ACTH get secreted in a diurnal circadian type rhythm, where your cortisol levels are going to be lowest at the onset of shortly after the onset of sleep, around midnight, 2 a.m. if you have a normal sleep pattern, and then they start to rise starting around 4 a.m. and peak around 8 in the morning. For anyone who's had an infant, you know infants do not have normal sleep patterns, and we're going to talk about what that means for newborn screening in a little bit. But this pattern of secretion starts to develop around 6 to 12 months of age, but it can take up to a full 3 years to normalize. And why do we need cortisol? You need cortisol because it helps keep your blood sugars normal, it keeps your blood pressure up, and it's really important in times of stress to do this so that you maintain that blood flow to the brain and to the vital organs. The adrenal glands also have other functions, and the adrenal cortex makes androgens, which help give you secondary sexual characteristics, or like acne and hair growth and when you're a little older. And then the adrenal glands also make mineralocorticoid, which helps you hold on to salt and balance your electrolytes. So what happens in ALD? In ALD, you get those very long chain fatty acids. They get into the zones of the cortex, and there are 3 zones of the cortex, and each zone makes its own hormone, and there are zones that make adrenal androgens, the glucocorticoid, which is your cortisol, and then the mineralocorticoid, which is what helps you hold on to salt. Preferentially, those very long chain fatty acids go into the zones that make cortisol and androgens in ALD, but they also can get into the glomerulosa, just not quite as commonly. So it's more common in ALD, but I want to be very clear, it's not only cortisol and androgens that are affected, but it's more common to find those show up first. And then later on, the mineralocorticoid can be affected as well, and you can have problems with salt wasting. So back to our picture, what happens? The adrenal glands stop making the cortisol, you lose that negative feedback, cortisol levels go down, ACTH goes up. And this is what we're screening for when we see the babies or older children. We're measuring ACTH and cortisol levels. So what are the signs and symptoms? Chronically, kids with adrenal insufficiency look pretty normal, and it's difficult to diagnose. They will come in sometimes complaining about fatigue. If they're really little, maybe they're not eating quite as well, maybe they're not gaining weight so well. And hyperpigmentation can sometimes be easy to pick up, but often it's very subtle and gradual over time. But the areas that you want to look for in particular are the genitals and in the creases of the arms, underarms, and the gums. And I'm going to show some pictures here shortly. Acutely, adrenal insufficiency can be life-threatening. So if you have another stress going on, like influenza, or you're having major surgery, all of a sudden, if your adrenal glands aren't working, you're having trouble keeping your blood pressure up and your blood sugars up. And that can lead to nausea, vomiting, abdominal pain, dehydration, altered mental status, and ultimately can be life-threatening. So we want to prevent this. This is just a picture of some of the hyperpigmentation that I was describing. This is a very, very classic looking hyperpigmentation of the gums. This is a family member who is unaffected. Oops, excuse me. Family member who's unaffected next to a family member who is affected, and you can see that there's darkening, and you'll often see it over the knuckles, in the creases of the palms and soles, nipples, and I do not show genitals for my pictures, but you will also see that develop as well. So what do we know about ALD? So we know that about 80 to 86% of boys and men with ALD will ultimately develop adrenal insufficiency. The earliest case report is because of newborn screening, and that is a 5-week-old baby. And we think females with ALD have a less than 1% chance of developing adrenal insufficiency. And I say think because this is based on mostly reports and really not any sort of systematic database and looking at this. And usually I have someone come up to me and say, I have a family member who has, a female family member who has adrenal problems at some point during the conference. So I'm just reporting what's out there at the moment, and this is, I'll get to what we need to do moving forward. The other thing that's important to know is we do not have a biochemical marker for predicting when this will develop or understanding which boys will develop adrenal insufficiency. So there are 2 studies that are published that look specifically at adrenal insufficiency and ALD. One, you will notice, was published in 2005. That is the only prospective study in the literature that looks at children who are boys who are known to be at risk and followed them up on average for about 4.5 years. That was from KKI, and with a very young cohort, they had 86% of patients after a 4-year period with evidence of adrenal insufficiency, and I think the average age was around 8 by the end of that study. The natural history study that the Netherlands and Boston did looked retrospectively and had the diagnosis of adrenal insufficiency was made sometimes by lab results, sometimes by the prescription of a hydrocortisone, and in those men it was about 80%. And the age of onset was a bit later in that group, around 14 was the average. So what do we do if we have a baby who's diagnosed? This is the picture I love to show everyone. I was like, this is 2012. So this is a year before New York State started screening. And these were the guidelines for monitoring. And when the first baby was positive and I got called, this is what was there. Refer to endocrinology. and that was it. And then Elisa started this conference, and you will see a lot of people in this picture who are still in this room right now, but way over here, I'm sitting there, and I'll cry because it's like, and there's Rose Marino, and the 2 of us, there was a second endocrinologist in the room that day, and the 2 of us sat together and we said, we don't know what we're doing. And not that we don't know what we're doing, but more that we don't know who to screen, when to start screening, how often to screen. And so we went around, we went to the Pediatric Endocrine Society and we said, who else would be interested in figuring this out? And so we got together, and this really truly is a consensus statement. We did our best to search the literature. At the time, there still is very little, as I just said, but we tried to base it as much as we could off of what is known about adrenal insufficiency in general, and particularly diagnosis in infants, as well as applying what we know about ALD. And so this is the general approach that comes out of those guidelines, are that once ALD is confirmed and the metabolic team has confirmed the diagnosis, We want the babies to come into clinic as soon as possible. And my personal goal is to see them within a week. I think it may not be always possible at every center, but the reason for doing it so quickly is really because I want to capture families early. We've talked about how scary it is at the beginning of with the diagnosis. And adrenal insufficiency shouldn't be scary. It should be, this is what I got to do, and this is how I'm going to treat it. And we'll go through that. So I really spend a lot of time just counseling families about what are the signs and symptoms. I have yet to have a young baby in my office and thought, oh, this baby already has adrenal insufficiency with ALD. But I think it's really important to have the screening done because I have been fooled already. And that is really important because adrenal insufficiency it's not obvious all the time. And I do this all the time. I see babies all the time for adrenal insufficiency with other conditions, and you can't always tell. And so, but that being said, I still counsel parents, I empower them, I give them patient information. I really appreciate all of the newborn screening programs and the advocacy groups putting things online. I print everything in Spanish for all my Spanish-speaking patients in the Bronx, and I have it all ready for them. It's really helpful, and parents appreciate, I think, getting something that empowers them to know what to do. So when we had to decide how to screen, I just told you babies don't have predictable cortisol and ACTH like older kids do. So they don't have that rhythm. But on top of that, babies have other things that make them special. And they don't make cortisol quite as much as those of us who are older, because what do they have to be stressed about? And then on top of that, the protein that binds the cortisol is also low in infants. So their cortisol levels at baseline are just kind of lower than the older kids and adults are. And ACTH has no reference range under the age of 3. So you have to really, it takes a lot of interpretation. And so when we sat together as a group, we came up with what we thought was a reasonable approach to how to interpret test results and a guideline. And then in terms of when to start screening and how frequently, I will also blame the Minnesota group a little bit too, but I think we got a little skewed by a couple of kids who came in who really seemed like they were early and progressed really rapidly, and we didn't want to miss those kids. But this comes back to, we need to systematically look at this and see really how often do we need to screen. And maybe there are some markers for some kids who need to be screened more often, and there are other kids who can go 6 months. But at the beginning, we tend to screen more frequently because babies are hard to diagnose based on symptoms. And as they get older, we can pick up symptoms. They start taking naps after school when they didn't. That should be an alert to call your endocrinologist. So under the age of 1, because they don't have that normal rhythm, I usually will offer parents 2 options. If they have to travel a long way to see me, or it's going to be a burden to come back to do repeat testing with ambiguous test results, I do offer them the option to do a cosentropin test. That way they don't have to do repeated testing. I also think for people, I grew up in a rural area, and we've talked about rural areas here this week. I think that it's also reasonable to have a primary care doctor do some of the initial screening before you get to the endocrinologist. And if it's ambiguous, then you can plan out doing that testing when you get to the endocrinologist. If I get back ambiguous test results, though, I do warn parents, especially in the young kids, that I might need you to come back. After the age of 1, 8 a.m. labs are usually reasonably reliable as long as the kids have a reasonable sleep pattern. And you can go to just starting 8 a.m. labs by the age of 1, and then we start treatment when it's indicated. So this is a crazy slide, but it's in our publication, and it's available for any endocrinologist. It's also based on older laboratory assays, which it does say in the very fine print. So some of the cutoffs, if you look at it, are going to be a little different than maybe what an endocrinologist might say their cutoffs are for their hospital in terms of cortisol. For ACTH, I told you there are no good reference ranges for under the age of 3. And so we used 100 as sort of our cutoff. That's the double, it's roughly double most adult reference ranges. And we said if the ACTH is under 100, you're probably okay right now. If the cortisol is really low and you're uncomfortable, you can always do that testing to make sure. But if the cortisols are reasonably measured and the ACTH is low, you probably don't have any adrenal insufficiency. If the ACTH is in this ambiguous range, which is 100 to 299, then you really need to use the cortisol to figure out what you're doing, and a lot of those kids end up needing a stimulation test. ACTH levels over 300 are considered maximal stimulation of the adrenal gland. So if the cortisol level is unusually low, so if it's less than, this says 18, but for newer assays, it's usually between 14 and 15, and the ACTH is high, then you really need to think that you have primary adrenal insufficiency at that point. So after these guidelines were published, I then followed up with a couple of case reports. I told you I was a little skewed when we were writing these, and we were talking about it. And newborn screening did pick up 2 babies who had biochemical evidence of adrenal insufficiency at a young age. And both of these babies, I want to emphasize, were not symptomatic. They did not immediately need to take hydrocortisone every day. But when they got sick, they got stress doses of hydrocortisone, and they got started on hydrocortisone at a younger age than probably they would have otherwise had presented. And it has prevented them from having an adrenal crisis. So it really emphasizes how amazing newborn screening is at preventing a major problem for a lot of kids. And just as an aside, I get phone calls about ALD and adrenal insufficiency from all over the country. And when there is a child who has an adrenal crisis and gets diagnosed with ALD, they're often in the ICU. They're incredibly sick. And before newborn screening, there probably were kids that we just never even knew had ALD and had an adrenal crisis and didn't make it out of the ICU. So having this knowledge and being able to treat early is really, really important. This is a publication out of California about follow-up, and this is going to lead to my point about what we need to do for the future. This is a very early follow-up out of California, and it's reporting who has adrenal involvement. And the numbers are small, but there are a small number of kids who are presenting really young with having adrenal abnormalities. Some of the definitions of adrenal insufficiency are inconsistent. And so some people will say, oh, there's a prescription for hydrocortisone that equals adrenal insufficiency. Some areas, depending on the family, their comfort level, the pediatrician's comfort level, hydrocortisone is being prescribed because they're thinking, well, if there's a problem, you have it at home. But maybe they don't have test results yet that really reflect it. So you have to be careful when you're doing your newborn screening follow-ups to figure out, was this just someone was nervous and gave a prescription of hydrocortisone? Was there sort of a borderline result that on follow-up was totally normal? Or is this a kid who has clear evolving adrenal insufficiency and needs hydrocortisone? So what do we do for treatment? Treatment is the same for adrenal insufficiency for ALD as it is for adrenal insufficiency for pretty much every other disease, with the exception of CAH. So standard treatment is just hydrocortisone. You either give it, if you need it every day, it's given 2 to 3 times a day, and it depends on the symptoms of the kid. Usually your highest dose is in the morning, and then you start going down on the doses as the day goes on. You do need to monitor for mineralocorticoid deficiency. There are no, you may have noticed that I only was talking about ACTH and cortisol, and that's intentional. As far as I'm aware, unless anyone in the room has anything different, nothing in the literature suggests that anyone develops mineralocorticoid deficiency before they develop the glucocorticoid or cortisol deficiency. So it's usually you just need to monitor for the mineralocorticoid deficiency once you've established that there is cortisol deficiency. And then androgen deficiency is incredibly controversial about replacement, and we generally do not recommend replacing with DHEA because it's associated with lipid abnormalities and worse cardiovascular outcomes. Long-term, anyone who's on hydrocortisone needs to be carefully monitored to make sure they're growing properly, make sure their doses are getting adjusted, and you need to make sure that you're not giving too much because that can also cause problems with growth. It can cause bone loss and muscle loss and raise blood sugars. And the other thing that's important is just to remember, especially the neurologists in the room, a lot of the anti-seizure medicines, but there's several medications out there that will alter hydrocortisone metabolism. So you may need to make adjustments depending on what's happening with other medications. Every child who has adrenal insufficiency should have a safety plan. That includes wearing a medical ID. I think last year someone brought a seatbelt ID also, or car seat ID, which is great, but it should be something that's on the child or the adult. Caregivers should have 24-hour access to an endocrinologist that they can speak to. I recommend having an emergency go bag that's just with the kid as they're like in the school nurse, with the school nurse or at home. And that go bag should have backup hydrocortisone. It should have the emergency injectable hydrocortisone, which I tell everyone I don't expect you to need. But if you need it, you should know how to use it and you should have it with you. And then they should have some sort of action plan. And everyone has different action plans. This is from a publication that the Pediatric Endocrine Society did. It's very pretty and it's colorful, although I think it has a lot of words on it. But the idea is that you should know this is my daily medicine, this is when I'm sick, this is when I'm in bad shape and what to do, and then what to do with surgery, which is complicated in a sec. They should have an emergency letter as well that they can just hand to any emergency room doctor that says, this is my condition, here's my doctor's phone number, this is what you should do when I walk through the emergency room while you're calling my doctor. And then for surgical planning, it's a little, we were talking about this earlier. I personally recommend that you get stress dosing for anesthesia, even if it's just a sedation, but not everyone does. And the reason I do this is because it's not just a sedation. If something goes wrong, there's a lot of stress. And so I just feel like it's a safety thing. It's once every 6 months. And this is a publication from Minnesota where they talked about stress dosing for their ALD men. And what they found is they had no events with giving the hydrocortisone. And that's kind of what I find too. If you give it, the anesthesiologist or the ICU doc who's doing the sedation knows, oh, it's like a reminder. This kid has adrenal insufficiency. If something happens, I need to remember that. So I personally do it, but not everyone does. And it's okay if they don't, but it's really important to make sure that the doctor's taking care of your child, knows that he has adrenal insufficiency and may need it. And then I'll wrap up with a couple more things. In terms of therapies, so hydrocortisone is standard, tried and true. We've been using it for decades, and we know how to use it, and it replaces what the body's not making. A lot of the therapies we've been talking about related to the neurologic conditions have very, very limited adrenal insufficiency evaluations in their publications. You kind of have to go through and read the fine print to see, was there anything there? The Lorenzo's oil study thought that maybe it slowed down the progression of adrenal insufficiency, but it was open label and very small. Bone marrow transplant has been found to not have an impact on adrenal insufficiency. It doesn't reverse it, but it also doesn't slow it down. Gene therapies thought not to alter it, although not published. And then I went and looked through the fine print of the publications for liraglutide, and there was one patient on it who developed it, and one patient not on it who developed it. And so if you think about the mechanisms, I don't expect it really to stop adrenal insufficiency, but I just want to point out that it really hasn't been really thoroughly vetted or studied, but it seems unlikely that it's going to influence it. And then just lastly, there's very little data on this, and most of these studies are from the 90s, but there are studies in adult men who have ALD who clearly develop testicular dysfunction later in life. And this is associated with lower testosterone levels. And it's thought that those same very long chain fatty acids that disrupt the cortical membrane of the adrenal gland also get integrated into Leydig cells, which are the cells that make testosterone, and that they interfere with they also interfere with the androgen receptor. And so a lot of men do seem to have a lot of symptoms related to testicular dysfunction later on. There are very few studies actually looking at this, and we really need adult endocrine colleagues to take this on. But androgen deficiency is a big comorbidity for a lot of men. It causes decreased bone mineral density, decreased muscle mass. It can be associated with mental health concerns, increased body fat, as well as decreased libido and sexual function. So it is really important to be aware for those who do take care of adults to be asking about these questions and making sure that they're getting tested. And then just finally, just future directions. I think that hopefully I've made the case that adrenal leukodystrophy newborn screening is really important. I think everyone has made that case this week, but particularly I think that it is saving kids' lives and identifying adrenal insufficiency early and allowing us to be able to get kids started in an appropriate manner on hydrocortisone. We do our best to attempt to predict when we think kids are going to develop and make sure that we're not missing the development of adrenal insufficiency, but I think that we really need more natural history studies to help us then go back and revise the guidelines. And I definitely think that there is a need for adult studies on androgen function and testicular function. The last thing I would just say is adrenal insufficiency definitions vary a lot, and I review a lot of the literature for adrenal leukodystrophy, and I think that it would be helpful for those of you who are going back to your endocrinologist to come up with a consensus for how we're defining it for when we're following up. I think defining it as a prescription of hydrocortisone given is probably not the best way of defining it. In terms of figuring out who has disease and when. I also think that there always is sort of a rumbling about, does adrenal insufficiency affect the neurologic outcomes? And that really is not known because we don't have good definitions for the adrenal insufficiency piece. And then thinking about biomarkers and revisiting the guidelines. All right. And I think that's it. I just want to thank everyone at ALD Alliance, the board, patients, parents, newborn screening centers, and everyone here in the room. Thank you. Any questions? Yes.
7 now, and he's still only just being stress dosed, which I'm very happy about. Do you have like a timeline of like, could that go on for 15, 20 years that he is kind of just needing a little, hydrocortisone when he has a fever or something?
Yeah, I have kids like that, and they're doing absolutely fine. Okay. They're happy. They're playing sports, and all of a sudden, like I have one that came to mind. It was probably like he was 4 or 5 when I started stress dosing, and he was 11. And his mom called me and said he's taking a nap every day. And I was like, okay. And right. We repeated his labs, and his ACTH it bumped up to like 400. And I was like, oh, yeah, you had been kind of smoldering with an ACTH of 125 and these borderline cortisol stim tests. And then he just flipped and started and we were screening every 6 months.
That's what we're doing.
Yeah. And I think that's perfectly reasonable. And by the time they're 7, they can tell you, my stomach's hurting all the time, or you see that they're not eating well, or they're taking a nap, and you're going to call, and right. And they'll get started. And he felt better as soon as we started the hydrocortisone. The naps went away again.
Okay, thanks.
You'd addressed the issue of stress dosing for sedation. And so a lot of us end up having the sedation done, and then we're traveling shortly thereafter.
Yeah.
Do you have any recommendations? Should we stress dose for longer? I can think of a situation with our family. We were in the middle of nowhere, headed towards Fargo back to Canada, and my son was not doing well. So would you recommend stress dosing longer post sedation if people are traveling?
Usually no, but that sounds like your son may have had a bad reaction to something that he was getting, which is also, again, the reason why I feel better giving a good solid dose. It usually lasts for 4 to 6 hours after you give it, and most of the time, well, it depends on your center. Some centers do the MRI, and then you're in the doctor's office for the next 4 hours. But if you're doing the MRI and then back in the car, I would say probably not as a routine. But I would have all of your emergency bag with you wherever you're going.
Thank you. There's a Zoom question. Oh, two Zoom questions now. I have to pronounce this for the first time. Regarding mineralocorticoid deficiency?
You
I
got
did?
it.
Okay. How often do we see this? There are some endocrinologists who state that it does not occur in this population.
So it's definitely documented to occur. And I get phone calls of kids who have electrolyte abnormalities and evidence of mineralocorticoid deficiency. So I never want anyone to walk away thinking it doesn't occur. It doesn't occur in isolation, though. So there are other adrenal insufficiencies where you can just have salt wasting, just have mineralocorticoid deficiency, and make cortisol still well. It definitely seems like a sequence that happens in ALD where cortisol deficiency happens first. And if you look at the MGH Netherlands study that they published, it was about half of men by the age of 56 had mineralocorticoid prescriptions. And this gets back to what their test results were and why they started, I don't know. But I had a phone call a couple weeks ago of a kid who had a salt wasting adrenal crisis with ALD, and clearly it happens.
Thank you. And then this is a good question. Has there been any work looking if there is a link between the age of onset for adrenal insufficiency and then age of onset for cerebral ALD?
I'm not aware of that, but that is something that needs to be looked at. So this is a plug. Newborn screening, I think Joe walked out, but Eric and I worked together to come up with a follow-up plan of questions that New York should be asking. And I'm sure that Joe will share with anyone who wants to do newborn follow-up, because I think that is a question that we need to answer for people. What? For today, we don't have, no. We don't have evidence. It does seem that the boys who have adrenal insufficiency are at higher risk, but not every boy who has adrenal insufficiency gets cerebral disease. And we don't know the average timing for one to the other. And the newborn screening has to help us with that, because a lot of boys with cerebral disease before newborn screening got diagnosed with adrenal insufficiency after they got diagnosed with the cerebral disease, because they had neurologists who said, aha, this is associated with adrenal insufficiency, we need to do labs. Yes, Katie.
When you're looking at the newborn screening data, I think it might be biased in the sense that if you have adrenal insufficiency, you're probably not in that gray zone. And so it might seem that way, but we've transplanted plenty of boys that have no, so I think it's risky to.
I also have had boys with cerebral disease who have been transplanted who then develop adrenal insufficiency also. I want to be very clear that you don't have to have adrenal insufficiency to have cerebral disease.
But I don't think that all the data I've ever seen, the idea is that it is not predictive that you are going to develop cerebral disease. I think in light of newborn screening,
I understand what you're saying.
It takes you out of that gray zone, so it might, because you probably are not in the gray zone then, right? You probably have disease, but I think
yes, if you have a clear adrenal insufficiency, and I want to be a clear adrenal insufficiency, not just a prescription for hydrocortisone or a borderline result, because there are borderline results, and those borderlines can sometimes come back completely normal the next time you check. But if you're clearly adrenally insufficient, I don't think you're in the gray zone. That's clearly a pathogenic variant.
Right.
There.
I'm just not sure where. I've never heard data presented, maybe I'm wrong, that having the adrenal insufficiency puts you at higher risk for cerebral disease, which I thought was what.
No, I'm sorry. I wasn't saying that. What I was saying is that if you have that, it means you have a pathogenic variant versus, yes, I'm sorry. I apologize if that was, that may have been unclear on my part. Sorry. That's okay. Any other? Okay. Thank you. Oh, sorry.
Can you clarify your stress dosing with anesthesia recommendation? You were only recommending stress dosing in children with evidence of adrenal insufficiency?
Correct. Yes.
Because that was not what was said. And I'm worried that people might have heard that.
Oh, no. Let me be clear. Only children with adrenal insufficiency need to have stress dosing. So if you have an infant who just had, a 1-year-old who just had normal testing, no, you only need stress dosing if you actually have adrenal insufficiency. Thank you for the clarification. Anything else? Okay. Thank you.